thank you all for joining me here. Again, like Dr. Matson said, I will be speaking to you about the integration of mental health and primary care services. I have no disclosure, so I'll jump right in. As many as 60% of your current patients could possibly have an undiagnosed mental health illness that they are not currently seeking any treatment for. As many as 60% of your current patients. The words that you see projected here are harsh. They're harmful words and very hateful words. To be honest, I even hesitated about including them in my talk because of the impact that they may have. However, I felt that it was important to show these words and to talk about the attitude behind these words, because it's that attitude that contributes to the stigma that is mental illness in our society. Many patients that are primary care patients, for instance, have been told by society, by friends, by family, and by some medical providers that they should just get over their emotional and mental problems. Just get over it. We need to focus on your diabetes. Likewise, many of our mental health patients have been told that they just need to get over their physical illnesses. For instance, do you really have a headache? What about your stomach? Does your stomach really hurt, or is it all just in your head? They've been told that they just need to get over it. However, there is a lot at stake for all of these patients. There's a lot at stake for our primary care patients. There's a lot at stake for our mental health patients. Rates for morbidity and mortality are higher in patients that have mental health illnesses. They are less likely to seek help for their acute or chronic medical conditions. If they're primary care patients, they may be less likely to seek help for any mental health concerns that they're currently having. And we all know that we have those patients that are labeled non-compliant. They have mental health complaints, they have physical complaints. It's a lot for them to handle, so they've been labeled non-compliant. Currently, I work at the Johnston County Health Department, which is located in Smithfield, North Carolina. That is just about south of Raleigh, North Carolina. It's a rural county, and about 14% of the population is considered to be at or below the poverty level. In 2013, across the state, mental health programs suffered significant funding cuts, and Johnston County was the same. Our mental health clinic was in danger of being closed down, and many patients were going to not have an opportunity to be seen by psychiatrists. Fortunately, the Johnston County Health Department was able to absorb the clinic, and now the Johnston County Health Department and the mental health department in that county are merged together. In 2017, that should actually say, a physician extender was hired based on a grant that we received to see mental health patients and to get them linked up with our primary care providers. If they already had primary care but had not seen their primary care providers, we assisted them with making appointments. Most of them, of course, had no primary care provider, so we were able to get them appointments at our primary care clinic within the Johnston County Health Department. They were referred by their current psychiatrist for lots of reasons, such as needing tobacco cessation, nutrition counseling, if they had abnormal vital signs. They were referred to the physician extender, and they were able to treat them that same day, which was extremely important. They were able to get their labs drawn that same day. And also, just as importantly, we were able to follow up with them by making appointments for them in our primary care clinic or with their existing primary care provider. Also, I decided to do an online survey to get the perspective of medical doctors and physician assistants. I wanted to know what the attitude was about incorporating mental health into your everyday visits, how comfortable providers were with incorporating mental health, and whether or not they even knew about resources within their own community. So it was a short survey that I was able to do to help to assess what their attitudes were. For our health department, just going back to that for a second, we were able to see over 330 patients that were referred to our physician extender. So over the course of 1 year, they were able to see all of these patients. They were able to help the mental health patients with their physical complaints, get them back on diabetes, hypertension medications, and they were able to get them linked up with primary care providers. Unfortunately, the grant was not renewed, and the physician extender working on that particular program is no longer there. However, the good news is that because of working on this program for a year, we're better able to collaborate as a whole. So for instance, if there are mental health patients that need to be seen, we're able to get them over to primary care, which is just across the parking lot, and we're able to see them much quicker than they would have been seen before. We have a much better relationship with the psychiatrists and counselors in terms of talking through patients and knowing what's going on with the patients, so that is still standing. The provider survey, I received 15 results from the online survey that I sent out to providers. It's not a high number of results, but I did get some very interesting themes. Well over half of the respondents knew that collaboration between mental health providers and primary care providers was vital. That collaboration and that integration will result in overall better health for their patients. They were also a significant amount of the respondents were concerned about making referrals, just really not knowing where to refer patients to, not knowing what some of the resources were within the community, or just frankly saying that there are not enough resources in the community. Also, 100% of the respondents knew what to do, and this is very, very important, knew what to do if a patient that day said that they were suicidal. So please make sure that if a patient expresses any suicidal ideation, that you know the roads to take and exactly what to do. However, a lot of the respondents thought that incorporating mental health into an everyday visit, for instance, if someone is there for diabetes and they're showing signs of depression, they felt that incorporating that would take a lot longer. And you all know we don't have a lot of time to spend with our patients as it is, and the perception is incorporating this may take even longer, and a lot of the respondents were concerned about that. So the struggle is that referrals and resources seem to be the major theme. A lot of communities just simply don't have lots of psychiatrists. There are not tons of counselors or social workers that providers are aware of, and that is a major barrier to access to care for our patients. Also, time. Time was a major theme. Having the time to work it all in, having the time to refer patients, and spending more time with them. However, collaboration across the board, people that I talked with, people that filled out the survey, collaboration, they know, is the key to success for our mental health patients and our primary care patients. So some conclusions. It seems that the trend is that by 2030, depression may be the #1 cause of morbidity in wealthier countries, such as the United States. The #1 cause of morbidity can be a mental health illness in the very, very near future. So this is something that we have to get on board with. We have to be able to recognize depression in patients and anxiety in patients and other mental distress in our patients. Substance abuse, opioid epidemic is a huge barrier, and it's an ever-growing problem. Providers, we know how important it is to work with our other care team members, but knowing what the resources are is vital. However, a lot of smaller communities and some larger communities just simply lack resources. And some recommendations. Because time is such an issue, there is a short 9-question survey called the PHQ-9 that you can download and you can use and assess patients' concerns about depression, for instance. So if they note that they have some questions or they're concerned or you're concerned, this is a quick tool that you can use. You can score it. You can decide if you need to refer them or if you need to bring them back for another visit. Also, go ahead and identify resources in your community, even if it's just one psychiatrist or one counselor. Get that person on speed dial so that if there's a patient you're concerned about, you'll have their number and you're ready to go with it. Alliance Behavioral Health, it's a great organization. They're available in multiple counties within the state, and that's a great first place to go to find out what resources are in your community. Seek out CME activities that talk about behavioral health. Mental health issue is major concern in this country and worldwide. So seek out more education opportunities so that you can learn more about it. And adopt a care team approach, not just working with psychiatrists and counselors, but also community volunteers, working with your church community, working with other communities of faith, working with patient advocates. Creating a care team approach, because your patient will see you for 10, 15, maybe 20 minutes at a visit, but then they go home to a community and you want to know who is in their community that can be a partner with you and that can help them to absorb the information that you have given to them. Thank you very much. If you have any questions, please let me know.